For those of you who don't know me, my name's Leidy. I'm going to be giving a talk today on psychotic disorders for the Social EM series. Special thanks to the Social EM team, specifically Drs. Graf, Udad, Ricachea, and Dr. Levin, who's from Psychiatry Department. There's a lot to get through today, so some things I'm going to have to go over a bit more broadly, but in general, today what we're going to be covering are these disorders, a historical timeline of the policy failures to understand how we got to where we are today, and then how to best care for and advocate for these patients in our ER and beyond. So today we're going to be primarily focusing on psychotic disorders, which I'll go on to define in a minute, but some of the material we're going to discuss today can apply more broadly to any patient with a mental health emergency in the ER. The term psychotic disorders, remember from med school, refers to a group of clinical syndromes defined by impairments in reality testing, specifically delusions, hallucinations, disorganized speech or behavior, and then negative symptoms. The DSM-5 breaks these down into schizophrenia spectrum and other psychotic disorders, which are specifically schizophrenia, schizophreniform, brief psychotic delusional disorder, and schizoaffective. But psychosis can occur in other things as well, like mood disorders, substance use, medications, toxins, or medical neurological illnesses. In the DSM-5, they're broken down by symptom profile, duration, relation to mood episodes, and the underlying etiology. But even with people grouped in the same illness, the course can be unpredictable. It kind of reflects the limitations of the DSM-5. You know, these classifications are somewhat arbitrary, reflecting our current understanding of psychiatric disorders and are more likely to change as we have more research. Okay, so we could really get into the weeds on the neurochemical biology of why these psychotic symptoms develop, but for the intents and purposes of this lecture, we'll describe it as altered neurotransmission in the dopamine glutamate pathways of the brain and move on. So the current hypothesis on how these disorders develop is that there's a strong genetic component and then influenced by a wide variety of exposures that have been identified. The genetic markers and modes of inheritance have not been identified yet. And then there's been many different risk factors associated with increased risk, but pretty like small effect size. So they're usually related to like neurodevelopmental insults like prenatal or natal insults, paternal age, stress, trauma, toxins, certain illnesses. In the emergency department, the number of psychiatric patients has been steadily increasing. Nationwide, we have an inpatient psychiatric bed shortage, as well as a boarding crisis. So we already have a boarding crisis for medical patients, but for psychiatric patients, it's even worse. They wait 3.2 times longer than non-psychiatric patients for a bed. And then if you have to transfer them between facilities, it's often more than 24 hours to another facility. Which if you've been at downstate, you know it can even be multiple days depending on the patient's insurance or other systemic factors. Does anyone know what the largest mental health facility is in the United States? Yeah, LA County Jail. So how did we get here? Going back to the early 1700s, or so the 1700s, early 1800s, people with severe mental illness were confined to jails, almshouses, kept hidden in families in harsh conditions. There was no form of psychiatric specialized care. Psychosis was often seen as a moral weakness, a sin, a divine punishment from God. In 1817, pictured here is the first psychiatric hospital that existed in Philadelphia by the Quakers. Shout out Philadelphia Quakers. But they emphasized moral treatment, which was focused on structured daily life, calm environments, work, and kindness that they noticed like helped these patients. And then reformers, one of the big advocates for developing more of these state institutions' name was Dorothea Dix. And she advocated to a lot of state legislature, describing the conditions at the time of how these patients were living in cages, closets, cellars, stalls, pens, chained naked, beaten with rods, and lashed into obedience. So this advocacy led to a boom in the development of state psychiatric hospitals like this one, pictured here today. Initially, asylum had a positive connotation. They were seen as progressive institutions. They resembled like Gothic castles on large, beautiful plots of lands. They had that same treatment modality structure. There was really no type of medical intervention at this time, and there was maybe some somatic and occupational therapy, but they still really didn't begin to understand psychosis. but they did start to understand that it was a disease of the brain and less so spiritual. During this era, some medical modalities arose that we would now look at as primitive, but at the time were considered advancements. So things like insulin coma therapies, they would basically just give people insulin and make them hypoglycemic and have them be in a coma. Metrazole shock therapy and ECT therapy, which now today there is some ECT, but it's done under much more humane conditions. Basically, they would induce seizures in patients. It was very dangerous. And the first lobotomy was also performed in 1935, which was seen at the time as a miracle cure for schizophrenia, although we now know today that is not to be the case. There was still heavy stigma at that time. Psychotic disorders were seen as lifelong, disabling, incurable, and families were discouraged from public discussion, which likely led in some parts to the growth of these places. So basically, they became very overcrowded. They didn't have very strict involuntary detention laws, so they kind of became dumping grounds for things beyond psychiatric diseases, like elderly patients with dementia, to name one thing. And then basically, they also had a lack of funding to contend with that growth and no administrative accountability to really ensure humane conditions. So this is a picture of one of them and how they were housing people. A journalist at the time described it as, "We feed thousands a starvation diet. We jam-pack men, women, and sometimes even children into 100-year-old fire traps, so crowded that the floors cannot be seen between the rickety cots, while thousands more sleep on ticks, blankets, and on the bare floors. Hundreds of my own knowledge and sight to spend 24 hours a day in stark and filthy nakedness." So media exposés such as these, as well as the cost to improve these institutions, had started the foundation for the deinstitutionalization movement, which we'll talk about soon. At the same time, the first drug was developed and schizophrenia began to be conceptualized as a dopamine-related brain disorder. So the 1954 FDA approved Thorazine, the first effective antipsychotic, which dramatically reduced hallucinations and delusions for people and brought a hope that psychosis could be controlled. So as a response to these asylum failures, the government passed a series of acts that tried to explore federally funded community alternatives to institutionalization, which culminated in the Community Mental Health Act being signed by JFK here in 1963. And then the creation of Medicare and Medicaid provided that funding in 1965 to develop these programs. Interestingly, JFK, we don't know, had a sister who was institutionalized and had a lobotomy and was pretty hidden from the public family. The other act of importance was the LPS Act signed in 1967 by Ronald Reagan, who was the governor of California at the time, which was the first legislative attempt to reduce psychiatric institutionalization. So basically, to be involuntarily hospitalized, it's the same conditions as it is today, is that the person had to be imminently dangerous to themselves, others, or so gravely disabled that they were essentially a danger to themselves. And then the rest of the country kind of followed suit, and the era of deinstitutionalization was underway in the United States. But sadly, the government did not put their money where their mouth was, and yet again failed these people. So they're giving the local government money to develop community programming really without any accountability in place that this money is going to go to patients who were deinstitutionalized. So sometimes the money would be squandered altogether, or other times used to build like a community athletic center or mental health centers that really treated like middle-class patients without psychotic illnesses. And then the state governments were effectively cut out of the funding stream. So the recipient of the money had no basically incentive financially to prevent hospitalizations or to prevent incarceration or homelessness. Another issue that exists in our current system is that in 1960, the US Supreme Court basically found it unconstitutional to try someone if they're too psychotic to understand the trial process, which is a good thing. However, now we have the situation where basically you have patients who need to be admitted to a psychiatric state facility to get treatment in order to stand trial. But these psychiatric facilities are overwhelmed because we deinstitutionalized, we don't have enough of them. And now they're keeping all of these people in jail awaiting treatment to stand trial. And so it's happening in most states. They did some studies that found that 47% of this population were homeless and unsheltered. 2/3 were experiencing some type of homelessness at the time of their arrest, and half had received no mental health services prior to their arrest. And those who did were largely seen in the emergency settings like the ER or psychiatric ER. In terms of who's blaming who, you kind of have the cyclical blame pattern where the federal government is blaming the state government, who is blaming the federal government for not giving them money. The local government also feels like the federal government hasn't given them enough money. And we don't have really like accountability systems in place to really change what is currently happening. It's estimated that 3 times more people with severe mental health issues are in jails and prisons than in hospitals. Effectively, we've recriminalized psychotic illness in this country, and America's jails and prisons have become our new mental hospitals, which is pretty shameful. These jails, as we can imagine, do not have the proper resources or training to care for this population. So this is an excerpt from a journalist in 2023, Meg O'Connor, who said, during the few hours that people with mental illnesses are allowed out of their cells, they are shackled to tables. Some don't have real clothing. Others smear feces on their walls of their cells. Flooded toilets are a regular occurrence. People scream and pace back and forth. Cells overflow with garbage. In certain housing units, mesh screens line the railings of the upper level to prevent people from jumping. So to simplify kind of all of that historical context, asylums developed, we didn't fund them. We got rid of asylums, we developed community programming, we didn't fund them. And now we are where we are today with incarceration and homelessness. We have to, in order to change that, we have to basically eliminate the funding incentives that reward neglect of people with psychotic disorders. Clearly, there's someone benefiting from this current system, especially in the prison industrial complex. Some proposed ideas is that if you create funding mechanisms that force the same system that fails the patient to pay for the expensive institutionalized care. And then that accountability can be baked into the funding streams. And you could track it by primary outcomes of arrest, homelessness, incarceration, institutionalization, and give funding based on how well they're performing on these outcomes. It's sad that it feels like we haven't made much progress in the treatment of this population in the last 200 years, especially when you consider the medical advances that have been made. So now in terms of care that we can give these patients, coordinated specialty care developed in the 2010s. We now know that the duration of an untreated episode of psychosis is critical, and early intervention and comprehensive care can improve long-term outcomes for these patients. This approach combines medication with psychosocial support, education, family involvement. After the first episode of psychosis, ideally, patients will get a psychiatrist, a therapist, supported employment, education specialist, family educator, and case manager with the goal of maximizing recovery, reducing relapse risk, and helping them resume a normal developmental trajectory. A great community resource that does exist, which some of your patients might have, is an ACT team. Basically, they're multidisciplinary teams that deliver the same approach to care, but out in the community to patients who have been unable to participate in outpatient care just based on the severity of their mental illness or homelessness. They're available 24/7. They meet with their patients multiple times a week, and they are usually have small caseloads though. So not a ton of people have these ACT teams, but when they do, it really does help the patients. And they're usually psychiatrists, nurses, social workers, substance use vocational specialists, and peer support workers. So while strides in medical care and public understanding have been made, the laws and cultural attitudes ultimately dictate, what care people can get access to. In terms of health outcomes, patients with schizophrenia and psychotic disorders have a high risk of suicide. 4 to 10% of people with schizophrenia will die by suicide in their lifetime. It's especially higher after that first hospitalization when they're kind of grappling with the new diagnosis. Substance abuse is high risk, homelessness, violence by others, and then their mortality ratios, their average life expectancy is 10 to 15 years shorter than people without. In terms of violence, just to make a note of it, there is an increased risk compared to the general population, but that absolute risk is relatively low. So the point of this slide is basically that, most people with psychotic disorders don't commit violent acts, and they're more likely to be a victim of violence by someone else. In terms of, there's some positive health outcomes. So if they get care, the long-term functional prognosis out of 20-year follow-up recovery occurred in about a quarter of the patients, good to better outcomes in 36%, and moderate or better outcomes in 60%. I think in the ER, we have an exposure bias of seeing psychiatric decompensation. But even in our patient population, you have people come in with well-controlled symptoms who are able to, live in the community. And you might not even know that they had the diagnosis if you didn't see it in their chart. I want to take a moment to talk about stigma and how it affects health outcomes. On the public level, there are a lot of stereotypes about people with mental illness, dangerousness, and unpredictability, which is fueled by media coverage of sensationalized violent incidents or Hollywood depictions of psychotic disorders, and then the historical kind of understanding of these diseases as personal failures. Or seeing people as incompetent or hopeless, assuming that people with psychosis can't work, live independently, or make decisions. And then perceiving people with psychotic disorders as fundamentally different from normal people. Ellen Sachs is a USC law professor with schizophrenia, and in her TED Talk, if you want to take time to watch it at some point, she says, "We want what all people want, which is to work and to love." The consequences of this kind of stigma leads to social avoidance, discrimination, and holding healthcare, employment, reluctance of the public to fund these services, and then ironically making there be more people living with uncontrolled disease in the community. Structural stigma, we talked about the major issues in it. And then self-stigma, these patients can have reduced self-esteem, social withdrawal, and which worsens their outcomes and makes them less likely to seek treatment. So when you're in the ER and your room looks like this, and you see a psychiatric evaluation on your board, what are some of the things that come up for you guys when that happens? Yeah.
Yeah.
Or like thoughts.
I feel stressed out, but I feel like this might be a patient that's gonna detract, time and energy from other patients, and that it might take a long time to kind of sort things out for them, to evaluate them, make sure that they're comfortable and that they're calm, and it might become something disruptive, so I'm a little bit more on alert.
Mm-hmm.
Sometimes they're not very happy. They're just like so that's the barrier.
Yeah.
To be having conversations.
For sure.
I think similarly, depending on my different disabilities with heavy patient, not only in kind of psycho-emotional, but also in kind of departmental resources. So a lot of times the patients are on person one, there's 62 or 60 other things. And also I think there's some downsides of them being emergency, so I think that's probably
I always place in the worst area, like 17-18 hallway, where like people turn to the bathroom and like there's like a lot of stimulation around, and they can get like more hyped up as the time goes on, and like it can start to stress other patients out around them, and so it's just a stressful situation for everybody, including them.
Yeah.
This is one of the most emotionally impactful things we have to do.
Yeah.
Especially at this point, those who are not there of their own volition, to take away their own autonomy in the event that they don't have capacity, we not sedate them, get lab work for them, and like this very emotionally impactful.
Yeah. Definitely. I feel all the same things you guys have mentioned. When a patient is there against their will, you have minutes to decide whether this person has capacity to walk out of your ER or if you have to sedate them. This can be pretty dramatic. So it's not just, our type 1 thinking is making us be like stressed to see these patients. It's because there's a reality that seeing these patients can be very stressful. It can be very dramatic and public with the way that our ER is set up, as Kat mentioned. It's no longer just you and a patient, but it's you, a patient, nurses, PCAs, the patient's family member, hospital, police, other patients in the ER, people filming, social media. It can be very stressful to be the ultimate decision maker in that scenario. So I think as physicians, it's important to be aware of our internal states and our biases. Part of my motivation for wanting to do this lecture is some of the thoughts or feelings that come up for me in these situations. I see an agitated or psychotic patient and I feel like, "Ugh, I just don't want to deal with this right now." And I do deal with it and I still deliver appropriate care. But I think when you approach things that way, you're not thinking as much about that individual patient and extending them the same empathy you would others. It's not something I ever felt was an issue for me in med school, but I think the stress of the ER makes it a lot harder and therefore has to be like a more intentional practice to really push yourself to think about that person and what they're experiencing. So now we're going to talk about taking care of these patients in the emergency room, just with the broader concepts of the initial evaluation, sedation, restraints, borders, and resources. So to send someone to CPEP, though this is the reason why we're doing it, we are saying, that they're going to go there for evaluation to see if they're going to be involuntarily hospitalized, which the criteria for are danger to themselves, which is mainly suicidality, dangers to other, like homicidality or aggression, and then so gravely disabled that they're essentially a danger to themselves. I think that can be kind of a gray area and a lot harder to assess. So things that can help with that are, getting good collateral, asking about ADLs. But if you are in a position where you think, I think this person has to go to CPEP, and like Dr. Willis said, I think prioritizing them immediately, putting in that one-to-one if it's not already ordered, because sometimes they are missed in triage. And then with that one-to-one, if they have a high risk of elopement, definitely making sure that the charge nurse is aware, the nurse taking care of them is aware. We're like getting them into the yellow gown because patients, they will walk out within minutes. I've seen it happen. And there's been cases before of people walking into the street getting hit by a car or other terrible outcomes. So it is one of those things that if someone is high risk for elopement, you want to act on quickly because not acting on it can be devastating for the patient and for everyone else involved. And then for what is appropriate for CPEP, it's really conditions that they think they can reverse like within 2 weeks of treatment. So it's not for dementia, it's not for personality disorders, it's not from delirium for substances, which can be honestly kind of hard to tell the difference on sometimes. I think psych is a little bit better than us at sometimes telling when someone is intox versus primary psych, at least I feel that way. And then in terms of the initial evaluation, just for the sake of time to summarize this slide, just screen them for the things that they're higher risk for that we talked about and doing a good head to toe like physical exam because they might not be the best historian. Once you're able to, obviously, if they're agitated, it's not the time. So while hallucinations and paranoia the person has might not be real, the anxiety and the fear that they're experiencing is. And that's something that we can relate to as human beings and want to alleviate for our patients. If the patient is agitated, you first want to try to de-escalate, which can involve, calm tone, eye contact, decreasing the external stimulus, which can be hard in our ER sometimes, but if you can move them to a quieter room. And then if there's a particular provider that's triggering to them, having someone else take over. A good de-escalation question can be, what can I help you with? This person is still sometimes able to experience reality rationally, and they're scared and anxious about something and just want to know sometimes that someone is listening, was the advice that I got from one of the psychiatry residents I talked to for this lecture. But if you do have to give medications, you can first offer it to the patient. You can explain it that it's going to make you feel better, will help with whatever symptom, they're kind of expressing. Sometimes they will take it, whether that's IM or oral. But if they decline, you should still tell them why you're going to give them the medications and that you're going to do that. I'm not going to get into the specifics in this lecture of which medications, but you definitely want to make sure you have an antipsychotic on board if you suspect it's a primary psychiatric disorder. Sometimes you have to add a benzodiazepine just for the severity of the agitation or how quickly you need them to be sedated for safety. And then be aware of monitoring afterwards, and the side effects of each of these medications that you're giving. While it doesn't feel good to do something against someone's will, like medicate them, when I was talking to psychiatry, they framed it as, you're really giving this person a chance to experience reality. They're not thinking and experiencing life how they normally would, when they're decompensated. And this is kind of one of the only things that really can help them. Sometimes we are calling psych like right away and telling them, we're about to medicate, like, please come. And I think on their end, it's a little frustrating because they can't always like drop everything and come see the patient. And then also, if the patient is very agitated, they're not going to get a much better history than we are. And so sometimes once an antipsychotic is already on board, they have a better time being able to assess the patient. I think on our end, if we know we're getting psych involved, we have on our end, we're trying to get disposed. So I think it's something to consider. Like, you can definitely put the consult in right away, but if psych doesn't show up immediately, like, don't hesitate on giving these medications to help your patient. And then lastly, chemical restraints is not a thing. You can give sedation for agitation or for psychosis, but chemical restraints implies that you're doing it for the ease of the providers, or that you're trying to have them like not move because of ease for the emergency room. And it's actually illegal by state laws, JCO, CMS. So it's never something that you should document. You should just document the indication for why you're giving medications. In terms of restraints, mechanical restraints should be used as a last resort, because they pose significant psychological, physical, and ethical and equity related concerns. So they're dangerous. They've led to events such as aspiration, DVTs, pulmonary emboli, rhabdomyolysis, cardiac arrest. Psychologically, they are very stressful for patients. They give PTSD, feelings of helplessness, fear, and rage, and mistrust of the medical system. It seems like from patient experiences, it's one of the worst things about being in the inpatient setting. And then from an equity standpoint, multiple studies have demonstrated that even when controlling for all clinical factors, that restraints are more likely to be used in Black patients than in white patients. And then all of these reasons are why orders and documentation for restraints are required. Technically, they should be reassessed by a doctor like every 30 minutes, which is what psychiatry does. I think we could do a better job of that in the emergency room. I think just given our environment, sometimes we try to, cognitively offload, or a nurse is asking you to renew a restraint order, but you should really go and assess that patient and not just do it blindly and put in the order, or ask them, if it's not your patient, for the primary doctor to go evaluate for that. I have example of a case recently, but for time, we'll keep going. If you need to put restraints, have at least 4 people who are trained staff to take one limb each, and then use 2 if possible, and 4 if you need to. The head of the bed should be 30 degrees, and you should never have them prone, because that can lead to asphyxiation. And then just a logistical standpoint, HP can help you restrain a patient, but you can't give medication while they're physically holding them down. So you have to restrain them, and then the HP steps away, and then you can give the medication. If it's nurses, it doesn't, but there's like a legal jurisdiction there. So with psychiatric patients boarding in the ER, what are some issues you guys have had when you've had patients like boarding for days or things?
Not treating anyone medical.
Yeah, like ordering home medications is definitely really important. Taking the patient as a true sign out and taking ownership of them, going and reassessing, because you might catch something the first team did it, not because, they weren't being thorough, but the patient might tell you something now that they're calmer, or you might notice something on physical exam that, they were dealing with a lot more at the time, so they didn't notice. Yeah. Yeah. Yeah, for sure. It's probably like one of the worst places for a patient with a acute psychiatric need to be is in the emergency room, especially if you've been at downstate. Sometimes these patients wait for days, and their symptoms get a lot worse. So they might need higher levels of sedation than they would normally or with the psychiatric team, and not being afraid to kind of appropriately give them medication is a big thing. And then also with that, trying to really move the transfer process along. So every time you get signed out on one of these patients, checking in with psych, checking in with social work, they've now developed a pathway at downstate where if they don't necessarily need inpatient bed, they can go to CPEP, which is like a quicker transfer. Although I've still had patients wait a long time for that transfer. And then, yeah, paying attention to the time of transfer, because at that point, you're just changing their entire environment again and maybe taking them to a place they also don't want to go to. So I've noticed that can be a time where they get more agitated, or I had a patient run out during that time period. So, not just kind of offloading, but again, if there's going to be a change of care, being there when the ambulance gets there. Some other things that happen with boarders are, knowing who's on your team and how well trained they are with psychiatric patients. The BHAs at King's are really good. They have really good training, and you can see it, the difference sometimes between the way that they interact with the patients and the way that PCAs will interact with patients. It's not to disparage PCAs, they just don't have the same psychiatric training, and usually don't really engage with the patient, or at worst sometimes can further escalate them. So being aware kind of if someone is particularly triggering to the patient, sometimes just like switching the PCA has been successful before. And then HP versus the downstate police, hospital police at Kings County, I think are better dealing with these circumstances because they also, again, their training and their motivations are different. The downstate police are hospital state police. So I've had times where I've seen them escalate a situation because they just don't really, again, they're not thinking from the same perspective as hospital police, which is really more patient-centered. And they're thinking more from like a criminalization perspective. So do not be afraid to afterwards say something to the person that you think maybe could have done better, or report, because it's a way that we can advocate for these patients. Even when patients like are waiting for super long time, another way to advocate for them is to report. So at downstate, I think they got the CPEP transfer process because physicians just kept complaining and kept sending emails. Obviously admin's aware of it, but it helps when you like advocate for these things. And then, it can be really hard with these patients if they are coming up to you like every 10 minutes when you're at downstate and dealing with a busy room. But I think trying to focus on the systemic, your frustrations on systemic things will help you better take care of these patients, especially when you kind of know the reason why they're in this situation is not their fault, is the fault of all of our society kind of failing them to this point. In terms of resources you can give for patients, if they're stable enough to be discharged, NYC 988 is a good resource. Dr. Rekachea has a dot phrase if you ever want to use it. I think it's like dot NYC well or dot 998. I don't remember which one. They have a lot of mental health resources, and also can be helpful to tell the family because the family can use that number to mobilize the mobile crisis unit, which I thought it was some like big team in a van, but apparently it's just a psychiatrist in a Toyota Camry. But they can go assess the situation and help and call 911 only if the patient agrees to it, and help arrange transport to a psych facility. But it just, it might be preferable for the families rather than calling EMS to have a psychiatrist just come check in on the situation because they're pretty well trained in, treating these patients. And then additionally, 311, there are street outreach teams that can offer immediate assistance and transport to shelters. So any, thing that is a resource for homelessness in considering these patients, and definitely have social work see them. In terms of other referrals, putting in a catch consult if there's substance abuse, making sure they're aware that they can walk into the R building, even if, they're not deemed that they need to go to CPEP as a transfer. If they have concerns about their psychological state, they can walk over there. You can even, show them where it is and walk them there yourself if they can't find it. And then, giving good follow-ups, primary care, as well as any other appointments they need, just to kind of keep them plugged in to the system, so they don't fall through the cracks. But it can be very hard to get follow-up for these patients, especially if they're experiencing homelessness. So the goal of today is really to think about how we can better care for these patients, reduce our stigma, advocate for them in and outside of the ER. We discussed stigma today on a personal level. Ways to decrease that can be listening to people's experience with the disease, empathizing with them. Societally and medically, we can educate by correcting myths about violence, chronicity, and treatment effectiveness, and then advocate for our patients in the ER and give them comprehensive care. And then on a structural level, advocate for policy change, changing our financial structures to not reward failing these patients is obviously a bigger task, but even within our current system, supporting programming that addresses substance use and homelessness, many studies have shown that it's much easier to treat these illnesses when they receive that assistance and they have stable housing, their addiction is controlled. And then, policies that promote integration of these programs. And then that's basically it for today on the 30-minute lecture. But does anyone have any questions?